Welcome to Analyzing Healthcare by Scale Community, which is an education-focused organization comprising of passionate global healthcare leaders. Analyzing Healthcare is Scale's podcast series dedicated exclusively to unpacking the myths and foibles that have been directed at US and global healthcare for as long as we can all remember. Is US healthcare broken? The worst in the world? Perhaps, perhaps not. Let's find out together as we invite thought leaders of healthcare to share their views. I'm your host, Roy Bejarano. So we have Liz Fowler today, who is a champion inside of US healthcare policy throughout her career, seen it, done it all. Recently was the Deputy Administrator of CMMS, Center for Medicare and Medicaid, and the Director of CMMI, which is, I always find to be a mouthful, so I'm just going to refer to it as the Innovation Center. So beyond that, instrumental in implementing legislation that at this point in my life, I've gone on record as saying I like, which is ACA, which I think is a little contrarian for me because I'm sort of a libertarian at heart. But having said that, I'm a big believer in great regulation when you see it. So I'm a fan. And you've been an advisor to President Obama. You were an advisor to a senator who was the chair of the Senate Finance Committee. I interviewed Senator Burr, who was the chair of the Health Committee, only a few weeks ago. So that was interesting because we spoke about how those two committees do and don't speak to each other. So from a layman's perspective, you've done it all. So welcome.
Thanks. I'm really happy to be here. This is fun.
So my first question to you, given your journey, your experience, all that you've seen, how much more do you know about healthcare than everyone else?
I mean, it depends on what aspect of the elephant you're touching. You know, I know some of it really well and some of it maybe less well. But what I do know is the policy angle and sort of like, how do you make change in healthcare? How do you change? How do you think about legislative change, regulatory change, the role of the government, state government, federal government in driving what happens in the health system?
So we're going to talk about the Innovation Center first, and then we're going to double back to the time that you spent actually at the Commonwealth Fund, which is an academic center that focuses on researching US healthcare relative to other countries, which is a topic that I find important, very important actually, because I think it gives us a base, a foundation for which to examine ourselves. But let's start with the Innovation Center. So how many years were you there for, and what was that experience like? If you had to retell the story of your time there, what would that story be?
Well, I was there for almost 4 years. My last day was last Friday, and I started, yes, very, very recent. I started March 1st in 2021. So I was a Biden appointee, came in to lead the center during the administration's term, and now the administration is ending, and I've departed.
This is a time for change.
Yes, a time for change.
Every 4 years, you can set your watch to it, depending.
Sometimes 8, but usually
sometimes 8. What a kooky place. What a strange place. But you've been in Washington positions, appointed positions for 15 plus years, give or take?
Yeah.
So you're used to it at this point. Some of the kookiness. Exactly. You'll be back, I imagine.
That is the point of democracy, yes.
So the Innovation Center, as per its name, when I think of what it's done as a layman on the outside looking in, I see a heavy fee-for-service industry that existed before 2010, with the introduction of ACA, in my mind, doing two things. One, really cutting into the uninsured number in the US successfully. President Obama said that 40 to 50 million, I can't remember the exact number, I'm sure you know it, uninsured is unacceptable. We need to stop talking about it. We need to start doing something about it. And lo and behold, 15 years later, that number is 28 million, of which rough estimates, no one seems to know the exact number, give or take 10 to 15 million is illegal aliens. And so you're left with 15 million, give or take, that are citizens of the United States that remain uninsured. That's a very different number than 40 to 50 million. So one of the foundational reasons why ACA seems to have made a meaningful difference to this country and how it views itself, frankly. Second thing that ACA led to was the creation of the Innovation Center. I think I'm right in saying that. Yep. And with the Innovation Center, the creation of ACOs, accountable care organizations, they're now, I count some, give or take 800 of them. They're not all spread across the country evenly. They tend to be very focused, localized in certain states like California and Florida and Texas. But with that, not just ACOs, but all the work that the Innovation Center did on bringing value-based care reimbursement programs to predominantly primary care groups in this country, you have a large number of patients that are flowing through a performance-based as opposed to a quantity-based healthcare system. And I know that the Innovation Center focused on Medicare fee-for-service to start, and I think it's added MA recently, but I want to ask you that and get into a little bit more detail with that. How successful has the Innovation Center been in bringing performance-driven incentives to healthcare in America? What would you compliment and what would you criticize? Now that you're no longer
that was an excellent explanation of the Innovation Center and why it was created. Just a little bit, can I step back one moment and just why it was created as part of the Affordable Care Act? And that is because and I was on the Hill, like you said, I was working for the Senate Finance Committee, working on drafting and creating the legislation for my boss, Senator Baucus from Montana, and who was the chair at the time. You know, health reform wasn't just about covering the uninsured. And yes, we've made a huge dent in that. Now we're less than 8%, whereas we were 15 to 16% uninsured in this country. But it was also about trying to impose a system that, like you said, rewarded based on quality of care and outcomes rather than just a volume of care. And how do we lower the cost of healthcare and improve quality? And as staffers, we looked around and there really weren't a lot of ideas for how to do that. What was happening in the private sector? What were the ideas that recommendations for experts? And because we didn't have a lot of ideas to pick from, the Innovation Center was created. Like, okay, how about we create a center that is tasked with testing, and if there's a proof of concept, then scaling and figuring out a way to scale it. And so I think
all good words for healthcare. Just the word innovation, the word testing, and the word scaling. These are all interesting words for healthcare that you don't find across the world everywhere you look.
Exactly. And there's been a lot of interest by other countries. You know, how did you create it? Why was it created? What makes it run? So getting back to your question of whether it's been successful, I think it depends on how you define success. So in the statute, success is, we have generated savings on a net basis. So any sort of investments you make in primary care, analytic tools, they hire nurse practitioners, they have more care coordination, that sort of counts against the total and the potential savings at the end of the day is on a net basis. And so
that's for the audience, because not everyone is as fluent as you or me, far from fluent. So let's help the true layman out there. Let's give an example. So I'm a primary care physician, and I have a patient in the past that I was incentivized to see as many times as possible. Every time they came to visit me, I would get a consultation fee, a professional fee, and I'm a specialist. Every time I perform a procedure, I get a procedure fee. A hospital would get a facility fee, more. And that speaks to the rate of growth in spend in healthcare in the US between 1950 and 2010, which was only up from 1% of GDP to 5% of GDP to 10% to 16.5%, 17.5%, debatable what the exact number is. Then all of a sudden, I'm a primary care physician, and I'm getting paid a fixed fee every month for that patient, whether they visit me or not. So no incentive for them to come more often, but I am getting a fee or a reward for certain types of visits, certain types of diagnostics, checkups. And I'm also getting a bonus if I have asymmetric incentives as opposed to fully like upside downside risk. I'm getting a bonus if certain criteria, KPIs associated with that patient are met. Reduced hospital readmissions or admissions in the first place, improved health scores. And so with that bonus, I'm creating what you refer to as these savings. I think the Innovation Center takes credit for something like $18 billion of created savings in healthcare spend over a certain period of time. So less use of healthcare, intelligent reductions in use of healthcare has equated to savings. Is that sort of what we're...
I would add that you also have to improve quality. So are you improving the patient care experience? So it's not just about cutting costs. And I think this is where, in the past, people were unhappy with, HMOs, for example, where the incentive might have been just to not provide the care. But Now, if it leads to worse outcomes, somebody is hospitalized when they shouldn't have been, or rehospitalized when they could have stayed at home, or the patient care experience is not a positive one, there's reductions and consequences for that. So it's both reducing cost, but like you said, in an intelligent way or an efficient way, and also making sure that patient care isn't sacrificed or somehow harmed.
So you really focused on my experience of it from the recipient's end, speaking to a lot of clinicians out there and a lot of administrators, I call them managers, who deal with a lot of clinicians, feels like from the recipient's end that the innovation centers really buckled down on primary care.
Absolutely.
And so if I ask you to focus on primary care, and I understand why you would want to focus, because every specialty comes with its own KPIs, its own clinical KPIs that influence outcome and performance. Telling an oncologist that if they were to do X, if they were to provide the following treatment plan, they would receive better outcomes for their patients is a very different conversation than talking to a dermatologist about their patients. So focus makes sense to me because this is not easy, right? Getting into the statistics and saying 2.5 wellness visits is better than 4.5. So all of this requires a lot of analysis. So if I was to ask you, what are the 1, 2, 3, 4 best drivers of better healthcare outcome in primary care that you could hang your hat on and say, if only every primary care physician did X, our country would be exponentially better off? Is it number of wellness visits? Is it a certain type of treatment plan? What do you look at and say, these are the 3, 4 things that we really drove into the marketplace that made a meaningful difference?
I would say, and maybe it's best to provide an example, the sort of team-based care where care is coordinated, where your physician knows when you go into the hospital. Right now, most physicians don't get data. No one tells them, hey, your patient just went in the hospital, just so you should know this, and you can help manage their care once they're discharged. So I think I've met with patients, I've met with providers across the country. Just a couple of examples. I met with a woman who and her caregiver. She said, I was in the hospital 9 times last year. I just automatically went into the hospital to the emergency room when something went wrong. Now I have somebody who has come to my house, who's making sure I get my primary care visits, that if I have an emergency, I have a 24/7 hotline to call. Somebody comes to my house. I haven't been in the emergency room for a whole year. That to me is success.
So
Or
closing the gap through coordination.
exactly, like what do you expect from your provider? You have someone to call, somebody who knows your history, who knows your experience, and is there to help you and guide you and coordinate your care.
So that's not an easy thing to do, but it has been done many times if groups are committed to the benefits of coordinated care. And so, interesting question for you. If I'm in a closed network, or at least a coordinated network where my hospital data flows into my primary care data and that flows into my home care data, and everyone's speaking to everyone, and collectively we end up treating the patient much better and generate savings, how does the Innovation Center help those participants allocate the savings between them? Who takes credit for what in an example like that?
So first of all, a closed network and going back to the legislation, like if everyone could be part of that sort of closed system where everyone's incentives are aligned and working in the same direction for the betterment of patients, that would be great. But we have a very diverse, complicated, complex system where providers don't talk to each other. Your
And
primary
patients
care
move.
doctor may or may not know that you went
Yeah.
directly to an orthopedic surgeon or a cardiologist. And so this is a sort of means of trying to get them to coordinate better, try to manage care. And so you want to see that cost of care going down. You want to see low value care avoided and high value care provided. And you want to see the patient feeling like somebody is looking out for their health and they know who to call. So I'd say that's what we're trying to create, but in sort of a different system. And what it takes is data. It takes the analytics to sort of have patients on your watch list so you know the ones to watch out for. You can make calls, you can send them text, you can reach out to their caregivers and make sure that they're getting the care they need before something bad happens and they end up in the emergency room. And so part of it is the data and analytics, part of it is that sort of care coordination with nurse practitioners, a greater role for nurse practitioners, coordination with specialists. All of that we hope is happening. And I've seen enough examples that I do think it happens.
I've seen them too. What I find interesting, what I think is probably universal across the world, is the challenges of patients relocating halfway through the process. You're taking care of a patient in Paris, and I'm picking France for a reason, and all of a sudden they live in Lyon. The challenge of waiting on the data, you're taking care of a patient in Paris and you only find out that the patient ended up changing their behavior and you ended up influencing savings 12 months later. That's a long time to wait in operations, right? Usually operations, the sooner you get to results, the more you can act on those results. The challenge of the patient staying in Paris, but having a change of heart, I no longer want public health, I'm going to buy private health. And so all of a sudden a change of who's paying. So we see that in New York all the time, right? The US health system, employer-based, change of job, it's a highly liquid labor force, and you're with Aetna one day and you're with United the next. Where does that leave Aetna? So maybe less of an issue with Medicare, which is probably one of the reasons why Medicare Advantage continues to function at a pretty high level here. But a lot of the US citizenry is employed insurance. And so there's a lot of mobility there between those patients. So where I've seen value-based care, coordinated care, which I think is probably a better way of describing value-based care, where I've seen it work wonderfully is in these captive markets where it's Medicare, it's a community, it's an elderly community. It's a place where there isn't that much mobility taking place and you can actually monitor, track, and create value behavior changes, coordinated care over many years. Would you agree with that? And maybe that explains why this isn't national, it's somewhat local, the implementation of value-based care.
Well, I think if we want value-based care to be successful, it does need to be broader than just the Medicare program. What the providers tell us is, this is great. I like this approach to being paid, but I want to see this happening across the rest of my patients as well, whether they have Medicaid, whether they have commercial insurance or employer-based insurance. So, one of the things that we've been focused on and quite frankly have had the most challenge with is really this multi-payer alignment. How do you get all payers sort of moving in the same direction, like you said, and when patients are skipping around the sort of the under 65 population that does move around, it makes it a lot more challenging. So Medicare is a nice testing ground. It's also what's in the statute. The statute says test in Medicare, Medicaid, and the Children's Health Insurance Program. It doesn't say test in the employer-sponsored healthcare. So that's also part of why the Innovation Center.
That's fair. And all you can do is offer an example to the rest of the industry of what works, right?
Yes, and lots of conversations and trying to find new and different ways of bringing on other payers.
So let's talk about things that haven't worked that quickly, that well. So a few things that I find continuously interesting. Bringing value-based care, capitated payment programs, bonus-driven programs, risk-based programs to the specialty marketplace. And maybe we leave oncology aside for a second, because I know a lot of time and effort has been spent on oncology, including by the Innovation Center. Maybe even we leave orthopedics aside and just think about the entire space. Think about urology and dermatology and physiatry and everything, physical therapy. When you look beyond primary care at the US marketplace, you see and also let's talk about hospitals, although maybe for different reasons, but across so much of the US marketplace, you still see a lot of fee-for-service. Why is that?
Well, value-based care, it's not a great proposition for specialists who make a lot of money under the value-based system. And why would they want to change? And there's no amount of shared savings is going to make up for the difference that they could generate if they did that additional procedure, did that additional test. So value-based care, the proposition is strong for primary care, less so for specialty care. But I want to go back to something, though, because there's two schools of thought. And one is, and I've heard this articulated, you really just need to coordinate on the primary care side and give them data and information about the specialists, and they will help manage the specialty care. Maybe, but you still need something to bring in the specialists and align them to the extent possible. We're trying a number of different things, and we had outlined a whole specialty strategy with a number of different prongs. So one is sort of trying to bring them into the fold by actually giving them incentives. And we put out and I keep saying we, but it's no longer we since I'm not there anymore. But last year, we put out a request for information. Is there a way to think about a mandatory model that would engage specialists? So that's one way to do it. We have a mandatory in-hospital specialty-based model called the team model that takes place. If this administration supports it, it would go into effect January 1st, 2026, thinking about different ways of engaging outpatient specialty care And then there's the sort of, how about if we give primary care more data, more information, help them figure out how to find those specialists who are more efficient, more highly tuned to value-based care, and then let them do their job under the incentives in the system.
Yeah, look, there's a lot there. I'll try to make sense of it in my head. For start, I think the market is interesting in that there's no doubt that economic incentive influences a lot of behavior, but it doesn't influence all behavior. I can tell you, working with so many physicians over the years and their representative management teams, that everyone is very interested in coordinated care because everyone wants to be proud of what they do. And if they could take better care of patients with better informed decisions, if they could place themselves in a more pristine position in society and be less susceptible to accusations of waste, they would take that choice in many cases. Now, it doesn't help if you're providing a carrot in the pathway that leads to bad care. That's a bad incentive. But that doesn't mean that people's hearts aren't in the right place. I would say they are. There's a challenge. The challenge is, controlling patient behavior, but that doesn't mean that indirectly, by controlling primary care behavior in a very coordinated way, you don't end up incentivizing primary care physicians to refer to specialists who are part of the process of making the world more efficient, making patients better off, on board with change in behavior, change in treatment plans, on board with more communication. So you would think that those primary care, this is the reason why you pick primary care, right? You would think that they would have a lot of influence. But hospitals also have a lot of influence. And if hospitals need to drive outcomes into fee-for-service and heavy use, heavy spend, because they have eternally large bills to pay, they employ millions of people, that's a somewhat of an uphill battle. So I accept that. I will say this, and this is why there's so much to think about. I've been part of providing care and living in a changing paradigm driven by Medicare and driven by CMS. All of a sudden,
What did you think? Does it work?
Yeah, there's no doubt about it. So when CMS says you have to start reporting, and it makes that statement globally to all gastroenterologists across the country, and you have to start reporting your adenoma detection rates in the following approved data repositories so we can make comparisons. Usually there's sort of a boiling the frog scenario where year one, it's a request. Year two, there's maybe an incentive, a carrot incentive to do it. By year three, you get to a stick. There's a cost incentive for those that are really dragging their feet. We will deduct 2% of your Medicare rate if you don't participate. And when you go through those stages, you find the early adopters are willing and capable. They have the time. They want to be part of, doing the right thing. And the late adopters, you use the carrot effect with them, they come along as well. So CMS is very powerful, driving specialties, physicians to change their behavior. I also find the aggregation of data is very interesting. So that brings me to my next big question for you. If you got rid of CMMI, the Innovation Center altogether, and you took the role of government designing payment plans away from the marketplace, with technology, with the ever lower cost of technology and sharing technology, and the eye-opening effect of us providers of care, I'm not a clinician, but I'm at least in the industry, being aware of better ways of doing things, more coordinated, better brand associated with smarter care, happier patients that are less disrupted with bad care. Because at the end of the day, if you perform one procedure on a patient, the patient's probably happier than the same patient going through 3 procedures, right? So happier patients, faster care, better care. Wouldn't the market innovate and design interesting incentives for itself, interesting ways to coordinate amongst itself, despite this starting point of fee-for-service, which I agree with you, healthcare is special in that its foibles, its inefficiencies, its dysfunctionality creates very visible, crappy outcomes that last longer than the average industry. So long-winded question, but underneath that, don't you think the market would get there eventually anyway?
I don't actually, but well, maybe
So
it's
you're anti-progress.
no, it's not that they won't get there. It's they didn't.
They didn't.
Weren't getting there before
That's a
the
fact.
Innovation Center
That's
started.
true.
So there was an experimental Office of Research and Demonstration in the Center for Medicare and Medicaid Services before CMMI existed, before the Innovation Center existed. It wasn't able to make the level of progress that I think we've made over the last 10 years or 13 years or whatever it is, because they didn't have the ability to waive certain Medicare regulations. They had different standards in terms of what you could test and what you couldn't. And I think maybe it was a little less nimble. So, but on the other hand, if we figure out what works, and I think we're making progress in this point, if we figure out what works and what needs to happen, then maybe you don't need the Innovation Center in another decade. Maybe we know exactly what we need to do. We know exactly how to get there, and we know how to build it into fee for service, or maybe everyone has moved into managed care and you're under a capitation. I guess that's a whole nother conversation. But I think for now, you do need this function and this functionality and this authority to be able to test things and continue to make progress.
I asked the question, but I didn't share my bias. My bias is more variety is better in a complicated industry that has areas of sustained dysfunction, because it takes different approaches to try to unlock the blockage, right? We're not making progress on managing costs. We're not making progress on, and by the way, there's a lot of other countries that feel very blocked to me. They're very stuck on heavy hospital care, very little outpatient care. They're very stuck on, let's not coordinate between our providers. Let's just create these siloed solutions where patients literally get lost once they need coordinated care. Oncologists are not speaking to urologists. Urologists are not speaking to primary care physicians, and no one's speaking to the hospital. So yeah, this industry is unique in that, we get referred to as broken, the broken US healthcare industry. What's amazing is you travel, most citizens feel that part of their healthcare system is somewhat broken. Even Sweden, they have complaints there too. Believe me, I've done the reading. They don't love certain aspects, the Swedes, of their own healthcare. They wish their physicians were a lot more incentivized to really go the distance, go beyond. But there's sort of equal compensation, equal incentive for everyone, regardless of performance. So you have sort of these critiques everywhere. Japan, China is a long list of criticisms. So we're going to get to this global study in a second, but I want to come back to the Innovation Center one more time. So Medicare Advantage has run its own value-based care initiative to great effect, but it doesn't mean that there hasn't been areas for improvement, shall we say. And so a few that come to mind. One, and I was on the phone with a female CEO who launched a female-only primary care business that was all value-based care several years ago. She's been very busy. Her women captive market of patients support her. They rally around her. She's now in 5 practices. And she's seen her revenues decline. And it's not for lack of effort. And so the whole movement towards parity between Medicare and Medicare Advantage, it's caught a few people by surprise who are in the value-based care space, which is not to say that there haven't been groups that took great advantage of some of those incentives and made a lot of money, maybe above average, what we call economic rent. But it is to say that value-based care, unlike fee-for-service, requires more average administrators per patient because it's more complicated. And until technology substitutes for patient care coordination, provider behavioral management, right? Provider oversight. Until technology substitutes for all that labor, you end up seeing these primary care groups that have many different department heads, many different FTEs supporting those departments in order to get that same dollar for treatment. And so that very rich incentive that MA and other forms of value-based care programs provided initially, to some extent, it made sense to me because coordinated care is expensive. And then taking that away, are you left with some damage in the space that we probably need to invest a little bit more to keep those people invested in pushing this forward? What are your thoughts?
There's a lot to unpack there. I say Medicare Advantage, they might be capitated, but it doesn't mean that they're paying based on value to the providers who are providing care to the patients. So in many cases, they're paying, essentially fee for service and not based on value. So I wouldn't make the assumption just because you're paying a capitated rate to the managed care company that they're managing care and they're what we like to refer to as accountable care, that they're helping to coordinate and making their providers also feel accountable for cost and quality in a way that improves patient care. So I don't make the assumption that that's happening automatically.
So give me an example of that, because that's interesting to me. So I'm a primary care physician. I'm getting paid a capitated fixed monthly amount.
Well,
but still that transitions into a fee-for-service reimbursement program. How?
so
When?
the Medicare Advantage plan is capitated, but they're paying based on the Medicare fee
Fair,
schedule. That's what I
fair.
mean.
Yeah, that's certainly true for the specialists.
Exactly, exactly. So, they don't have a magic bullet either, other than that they're capitated. But
Yeah.
I think we're seeing a lot of inflationary spending in the Medicare Advantage side because of the,
So
way that the payments are set, and probably needs, a look under the hood to make sure that the payments are working the way that Congress and everyone intended.
remind me, I'm not in the weeds like you are. The MA plan, and I only have seen this anecdotally, and I read about it. There were articles about it, but I didn't dig. There was a reset of reimbursement levels, bonus sharing, whether you raised base levels, whether you took away star ratings that translated to certain bonus sizes, whatever it was that you used to try to reduce the spend coming out of MA and maybe the Innovation Center on behalf of Medicare as well. There was this moment in time where these value-based care practitioners suddenly saw themselves earning less. Maybe it was base level, what we compare for savings last year suddenly got rejiggered in an aggressive way. What happened? Why does the market suddenly feel that it's not getting incentivized and rewarded the way it used to be?
I think part of that also is some of the changes that CMS has made to risk adjustment and the HCC, the mechanism for rewarding patient or rewarding plans that enroll sicker patients. And so I think the pattern that we had seen was there's this inflationary effect of like, well, let's just code as many things as we can and find as many illnesses, and therefore
call everyone super high risk.
everyone has a lot of
Everyone gets a high risk score.
lots of chronic conditions, and
Yes.
therefore higher payments. If we refine that and make that more accurate, maybe there isn't as an incentive to do as many surveys and home visits and try to look at ways of finding more illnesses.
So this is this interesting wave effect, because I can tell you firsthand that I've been on the phone with operators who have said to me, oh yeah, no, I'm a value-based care primary care group. I know nothing about organizing doctors, but I know a lot about the coding. And that always seems to me like gaming the system. That's not a pleasant conversation to have. And those people are out there. Let's take advantage of the gaps, right?
Yes.
Let's score this way in order to get paid that. And then I can also tell you that they're not just physicians. It's not like, I don't buy into the biases. It's not like all doctors are bad or all doctors are good. It's not like all managers are bad or all managers are good. There are managers and physicians who are just trying to make value-based care work. And they, I think, have been caught up in the revised scoring methodology in a way that caught them off guard, because initially their business plans expected Y payments to support X resources. And they're still left with the X resources commitments. And that's an interesting happenstance or occurrence, because part of what I believe, and I'm asking you as a representative, part of what I think CMS does is it sets the table in anticipation that practitioners, clinicians, and managers and all the market will react, will come to your party that you're hosting saying, I buy into this. This makes sense, right? ACO REACH, you can bet on it. It's going to be there for you. And so sometimes, and this is a question, but it's also feedback, it's the sudden change in direction, which is perfectly justifiable. Hey, we learned that, there was abuse, or we learned that things were more expensive than we have to restructure them. But sometimes when that happens, what you end up doing is creating a lot of uncertainty. What are your thoughts?
Yeah, and I think that's right. So I think
But how do you avoid it?
right. How do you avoid it? Well, let me also say ACO REACH, I think the uncertainty there is that it's a model. It's a 5-year model, and at some point that's going to end. And so a lot of the investment that's been made, a lot of the participants are saying, well, what comes next? We've made all this investment. We're starting to change the way that we're delivering care. And then the program ends at the end of 2026.
I've seen that happen as well. Yes.
Exactly. And so I think that's where I think
it was called Direct before ACO REACH, that suddenly came and then went.
Yeah, global and professional direct contracting. So the GPDC model, we made some changes. And look, I believe in this model and the direction. I think we made our own tweaks when this administration came in place. We called it something different, and I think put an emphasis on some of the payments that we wanted to see towards caring for underserved populations. So we made some, and But the program still ends, whether it was GPDC or REACH, it ends at the end of 2026, and a lot of those providers are asking what comes next. And that's where I think we need to get better, or the Innovation Center or CMS needs to get better about providing that certainty and figuring out what works. And if it's working, then figuring out how to scale it. And so,
I've got an idea for you.
yes.
Disclaimers and selectivity. So, for example, hey, you're a community hospital, ACO REACH, let's do this. You're not going anywhere. You have a stable, almost monopolistic, in a good sense, place in your community. You're the place that patients come to for inpatient care. This is a good experiment for you. It's not going to last more than 5 years, but come along for the ride. Versus, hey, you're a primary care group that just launched based on the ACO REACH program. You know, you're self-funded plus a little bit of investment from family and friends. This is not a good fit for you. No matter how good it looks, we can't guarantee you year 6 revenues. This is not going to be for you. And I'm sure you already do that. I'm not telling you anything you don't know, but I think even more of that probably, thinking on behalf of the end user, what is prudent for them, because they don't always, they're entrepreneurs. They're hoping for the best.
Well, that, and we want to make sure that people are in these programs for the right reason, that they want to provide better care, improve patient experience,
They do.
etc.
They're following your lead.
Yes, but we want to make sure that they're in it not just because they see a potential to, take on that risk and make a buck. That this is
not to make a buck. Believe me, that the people that I'm describing, and I can think of them in my mind, I see them. They think this is the future of healthcare, as you describe it, and they're willing to assume that because it's going to go well, there's going to be continuity.
And
but
we need to give
that's a
them that.
bet to make.
We need to give them that certainty, and we have not done a very good job of that. So I think that's a challenge for the next administration to provide that level of certainty and maybe make it operationally and administratively less burdensome.
Hey, what I'm asking you to do is to experiment without breaking any china. That's not an easy thing to do.
Right.
Not an easy thing. And I wanted to make it very clear. For me, the fact that you're experimenting and testing and engaging with better ways to provide care in this country, with data and science helping to drive that, is so cool. And I say that as someone who's spent at least some time studying what other countries are doing. And there's a shortage of that everywhere across the world. So let's get into your views on US healthcare. This strange, exotic topic called US healthcare, which is my favorite topic for this podcast. So, we bundle into this a tech podcast and a CEO leadership podcast. But for me, nothing's more interesting than this question: US healthcare. Is it broken? Is it irredeemable? Is it unsustainable? Is it all the headlines that we've been fed for as long as I've been here? I've been in this country for 30 years, and I left the NHS in the UK and became a US patient. As much as I'm a US citizen, I'm a US patient. And I have to tell you, as crazy as US healthcare is, and it's certainly idiosyncratic, I'll give you that, it never felt broken to me. So what are your thoughts?
Well, you probably had good insurance.
I knew you were going to say that. I'm special.
Yeah. But okay, so full disclosure, I spent a summer working for the NHS in London, and I also spent a summer working for a German sickness fund. So I've been very interested in international health systems for a long, long time. And I think there are certain things the US system does very well and certain things that it doesn't do very well. And I think at the heart of it, I believe that healthcare is a right, that people have a right to healthcare, but not everyone believes that. And so I think there's this tug and pull between what our system should be. Should it be something where you deserve healthcare because you're employed, because you're, healthy, you're taking care of yourself, you're exercising, or is it sort of a fundamental right and you should have the right at least to basic healthcare? And I think I'm in the latter camp where I do believe it should be.
This question of rights is interesting in itself because as a foreigner who's still getting used to the idea of being American, it feels like Medicaid is available. And so we have a very large program that is larger than most countries' GDPs. 198 countries, most of them don't even get to the Medicaid spend. So we're here and we're taking care of those that can't take care of themselves. That doesn't mean that we've got all bases covered. 20 million illegals in America, hard
It's
to
not just
find
the
them.
illegals or the states that didn't expand Medicaid, taking advantage of the 90%, now 90%
Yeah,
federal matching rate. A
yeah,
lot of states that just haven't expanded. And if
yeah,
you're below 100% of poverty in those states, you don't have a right to any health care
yeah.
except you under the emergency medical treatment EMTALA that you go to a,
What percentage is that? Because that's
well,
a percentage that I would agree with you on is a strange one. You have the sick and the needy. You have a program, and as a state, you're choosing not to take care of those people. I mean, we run into this problem in America all the time that we make these declarative statements about who we want to be as a country, but we're sort of 50 countries at times pretending to be one country.
right.
But
Well,
what is this
I,
percentage?
I'd have to look at the numbers and I can get back to you, or probably not in the course of the podcast, but you're dividing that remaining uninsured,
Yes, the 8%.
right, right. And
So
you're trying to parse it
92%.
out. And
Yes.
I'm sure there are numbers somewhere, and I haven't looked at them recently, but
Yeah.
there's a good chunk of them are probably eligible for coverage and aren't getting it, or just
Yeah.
aren't eligible because of the state that they live in. And some states, even if you have Medicaid, and Medicaid has become an increasingly important program,
Yeah. You
in
don't
this
qualify. You've
country.
got a little too much income and you're a little above the threshold. You're out.
Yeah, yeah,
Now you're
exactly.
relying
But
on the employer
well,
marketplace.
adults, you don't, you may not have steady employment. And if you look at employer offers of coverage, that has been going down. So it's not just because you have a job that you get health insurance. Many employers don't offer that coverage.
Yeah, we've
The
got a
marketplace.
large 1099 marketplace. We've got floating employees. We've got Cobra that takes care of in-betweens, but not in perpetuity. And yet, percentage of insured, let's start with that, is 92%. And so what we're talking about is the 8%. And so I have more of sort of an economist's heart, and I have to say, I have to ask the hard questions. Let's be careful of overly criticizing the 92% and hurting the 92% in an effort of trying to help the 8%. That's sort of the statistical logic behind it. There's programs that should be improved for the 8%, but we have to look at each side of that equation objectively. Are we doing a good job with the 92%? So your first point is you're not happy that there is an 8%.
Not happy that there is an 8%. And you're right. And I think that the beauty of the Affordable Care Act was it wasn't trying to upend everyone else's health care. And you might remember the mantra, if you were living here, if you like what you have, you can keep it. The idea was not just that you get exactly the same thing and you can keep exactly what you have. The idea was that if you have employer sponsored coverage, we're not going to take that away from you. You can still get employer coverage, but if you retire early, if you're part-time, if you don't qualify for some employer coverage, there's a place for you to go to buy and find affordable health coverage. And that's the marketplace. That's the exchange. And that was what ACA tried to fill some of those gaps.
I think what you ended up with was beautiful. And I think it was really actually quite bipartisan. I think where you started, not so much. So the wrangling and the rewriting and the rejecting and then the coming back and all the machinations that it took, it was like the days of LBJ, true politics at its best. It's interesting that how the sausage was made. Part of it was realizing that, the commercial space, the 92%, there's a lot of joy and ownership in what citizens have in this country today with their healthcare. Don't take my healthcare away from me. That's not just 65-year-old grannies. That's a lot of people. And so there are all these sort of interesting statistical behavioral anomalies that call into question this idea that we don't know what we're doing in America. It's a long list of them. I'm excited to go through them with you. We got a little bit of time left, so we're going to get there. So the 8%, which is arguably 4%, because a good chunk of that is illegals, and that's a different conversation. It doesn't mean we shouldn't be there and taking care of everyone. Anyone who steps foot in this country needs help. Period. They're in our country. We're the host. And by the way, most countries feel that way. You're a human being. Pick a country. You're in New Zealand. You have rights. We have an obligation to take care of whoever's here, however they get here. But it's not necessarily the same conversation as an economist to say, and our industry needs to have limitless supply no matter what the circumstances are, because no country can make that obligation, that commitment. Every country has limited resources. All right, so let's keep going down the what's wrong with US healthcare. What else don't you like about it? What else does it do?
Look, it doesn't.
What I'm going to do is share something that you were part of. I don't know to what extent you were part of it, but this is the Commonwealth Fund website, and this is their publicly available analysis. This is recent. This is what journalists across the country refer to when they write the headline, "We are terrible." And it starts right here. Healthcare rankings, overall ranking. Here are the countries that we're comparing ourselves to. And out of 10 countries, the US is 10th. Last again is the way that the headline reads. And so verbatim, this is the report that finds its way into the journalist publications across the world that believe this to be scientifically sound. What are your thoughts?
I mean, I think it depends on how you're defining high performing, but I think there are aspects of the US health system that really aren't high performing. The number of people who forego needed care because they can't afford it, they either don't have coverage or maybe their cost sharing is too high, their coinsurance rate is too high, who forego medicines because they can't afford the price of the prescription when they go to pick it up at the pharmacy. I think there's also the notion that we don't spend enough on.
I'm going to take this one point at a time because
Okay.
I'm stubborn because I think I'm just a little less sharp than the average tool. Maybe it's dyslexia or whatever you want to diagnose me with. It just takes me a little bit longer. So do you think that we are consuming less care than other countries? So even though we're at 17.6% of GDP and our GDP is greater than any other country, and when you do the maths, we get to over $5 trillion of spend, which is the size of Germany. Actually, we're consuming less care on a per capita basis. Where does that information reside in an analysis like this? Because I didn't see it. And I actually don't agree with it. I think we're consuming more care.
Yes.
Not to say.
Depends on who it is.
Right, which is not to say that it's always the right care for the right person.
Exactly. It's not a distribution that always makes sense. And I've used this example before. My mother told me, she's been having shoulder pain. My doctor told me I need shoulder replacement surgery. And it turns out, no, she needed physical therapy, not shoulder replacement surgery. So if she gets the shoulder replacement surgery, it doesn't mean that it was needed care. It doesn't mean that it was an efficient use of resources. And it goes to this overall bottom line. And I'll tell you, the best analogy I have heard of the US system compared to other systems, and I'm curious if you agree with this, and it was Senator Daschle, former majority leader in the US Senate, who said, the difference between the US and other countries, if you think about healthcare as a pyramid, and at the very top is the highest cost, most expensive, newest, best, Cadillac version of healthcare, and at the bottom is very community-based primary care.
Yeah.
Most countries start at the bottom and everybody gets some level of primary care, but they don't make it quite to the top. And so maybe you don't get that, exactly what you need, exactly what you want, exactly what you think you need. The US, in contrast, starts at the top and we never get to the bottom. So we are willing to give people the best, the newest, the most expensive, the most sophisticated, but then sometimes we don't do a very good job of getting primary care at the bottom. And I'm sure there's lots of imperfections. You can come up with all sorts of examples why that's not true. But at least to me, it explained what I see and what I've seen in my career as, it would be good if everyone had some.
You're describing equity. And so I want to spend a lot of time on equity with you because I think in many ways you're right, but I think we're uniquely challenged. So the chart, this is on Scale Community. This is something that is a personal project of mine. So one of the charts that I find most interesting is this one. So this is US life expectancy for the top 1% in the US. It's 84 years of age, combined genders, male and female. If you break it out by gender, females' life expectancy is actually higher than this. This is US life expectancy for the bottom 1%, 76. That's a 10-year gap. This is blue is England. So this is the UK. Sorry, we are red. This is our life expectancy, 74. So this gap here down here is a gap of equity. When we get higher and higher in income, our healthcare is comparable. Our top 1% versus their 1%. We're both getting great care. As soon as we start moving down the income ladder, we start seeing that we score worse in equity. Is that fair?
Yeah, I think that's an interesting chart. And I think that is what the Commonwealth Fund report is getting to when it talks about equity.
Yeah. So The challenge with, and I'm going to go back to the Commonwealth Fund, the challenge with data, as I've learned many times before, is that it hides a lot of, beyond nuance, I would say it hides a lot of truth. And you really have to keep digging, like an endless hole to get more and more truth. It's like trying to describe the Japanese economy 1990 or 1985. Yes, fantastic in the automotive industry, amazing in certain aspects of technology, discs, Sony, you name it. Absolutely dreadful in other industries, whether it's the housing industry, no commonality in building houses across Japan. So no secondary market for housing in Japan. Just all kinds of dysfunctionality. So this blanket statement, Japan's going to eat our lunch, which was going around in 1985, this was helpful to journalists, but not necessarily true of reality. So here we come into the US marketplace, broken healthcare. And here we have Commonwealth telling us that our healthcare is broken. Here are some of the issues that I have with this analysis. One, I don't understand the country selection. It doesn't make any sense to me. To compare US healthcare to New Zealand, you would be better off comparing US healthcare to lower New York, Manhattan, sort of a similar population size. New York City is 10 million, New Zealand is 10 million. So why doesn't New York City, not even New York State, fall in this comparison? So New Zealand doesn't belong here. Get rid of it. To not have China.
Probably Commonwealth countries. So I think the point is that you start with Commonwealth
Commonwealth,
countries.
as in the British Commonwealth?
Right.
Are we doing something for the Queen?
No,
Or are we trying to
I think that was the starting point, and then a couple of others are added. The same thing, you see similar results in
let's be true scientists here and forget nomenclature like Commonwealth. We don't owe the Queen a healthcare analysis. This isn't for her benefit. This is for our journalists. So let's be honest. Let's be accurate.
What would you add here besides New York City? Would you come up with a country?
Oh, there's no way you can compare US healthcare without comparing China, without comparing India, and without comparing Russia. You start with those three countries because we're 350 million people. And so we have the obligation of taking care of 350 million. And what you find when you take care of 350 million, 200 million, a billion, is you're going to find variance of extreme proportions. It's very hard to manufacture homogeneity the larger you get, the more you scale your country, because there's more room for variance. So I'll give you a perfect example. US counties have, in many cases, the highest life expectancy in the world, and it's sprinkled across the US, including in parts of Alaska, which in its entirety is very unhealthy. But there are counties in Alaska that fish all day long, they don't smoke, they don't drink, they're very active, they have really strong communal bonds, they're sort of like blue zones. So we have these sprinkled blue zones all over the country. Certainly Southern California is probably the most famous, parts of Colorado, less so Tennessee. I mean, I find this statistic really interesting. I don't know if you still see it, but I'm going to go back to this dashboard. Do you see this dashboard?
Yep.
So I'm going to go to rate of myocardial disease shown on a US map. So here in blue, in Arkansas, Missouri, Alabama, the rate of myocardial infarction is over 2 times, 3 times in some cases, states like Montana, Nevada, California. These are 2 different countries living 2 different worlds.
There is a lot of variability, and that has definitely been demonstrated.
Yeah. So when we go back to this analysis that ranks us last based on life expectancy, and when you talk about health outcomes, the only data point that's right, I just, in general, I think there's far too little being analyzed.
Outcomes you're looking. I mean, mortality rate, maternal mortality rate.
Hold on. Yes. Hold on. So can I find life expectancy? Yes. Americans live the shortest. No, they don't.
Well, on average, I think it's.
I know, but now we're getting into the trouble with average. And
yes,
it's my primary issue. American healthcare.
But couldn't we aspire to bring everybody up? Couldn't we?
Yes, we can. Yes, we can. But I have a stubborn mule. I'm going to help us bring everyone up what I think is the right way. And the right way is to say, we have to bring everyone up. That is the right standard for America. But also, so proud to become American, the right way is to be scientific about it And the science says the following. A lot of what America does, I'll give you an example. Let's go back to.
On the other hand, we've known for decades that there are disparities and we haven't done anything about it. And so,
yes, I spoke to Senator Burr about this because I disagreed with him. I was taking your side of the argument. So I'll come back to that in a second. We haven't done anything about it. So liver cancer survival rates, there's New Zealand again, there's us, third. Joint second, third in the world. Lung cancer survival, there's us, first. This is not a small thing. There's a lot of lung cancer. Breast cancer survival, even more of it in the world. Who's first? That would be us, the United States. Highest survival rates in the world. We score highly in critical healthcare stats, outcomes. And what happens is you get a journalist who just rushes to this life expectancy number, 78, even lower during COVID, 76. We're dreadful. And what you do is you end up ignoring that most patients in the world, when they get really sick, try to come here. You ignore that. And
they have the means to do so, when they have the ability and
oh yeah, no, forget the means, forget the wealthy, forget inequality, forget equity, just forget that for a second. And just the question of health care is a very interesting one, because actually the definition of healthcare is far narrower than what the average person is willing to understand and appreciate. Most people associate any health condition with healthcare. Here's my definition of healthcare. How are the hospitals doing? How are the doctors performing? How are the practices? What's the access? Where are the nurses? What's the treatment plan? Is Liz Fowler running the innovation center? Because if she is, I'm happy, right? Is Obama driving ACA? My wife will never speak to me again, but that's how I feel. I'm happy because ACA, I'm a fan of what I see with my own eyes.
She's not a fan.
No, but that's okay. It's a big world. There's room for everyone, right? But my eyes can't lie to me. Good regulation is good regulation. Good outcome is good outcome, wherever it comes from, right? So that's the definition of health care, right? Not what are our obesity rates, which is the definition of our food industry, the definition of our behavior as citizens, the definition of our education system, the definition of our cultural divide, the definition of local evolution. New Orleans food intake is very different than what's a beautiful town?
California.
I was going to pick
Napa
a town,
Valley.
Napa Valley. I was going to pick a beach town in southern, right? But that's the foreign in me. I can't even think of these towns, but not the same. And so everything gets combined into this 78-year number. And I'm a big believer in adjusting. We adjust, as I'm a former banker, a recovering banker a long time ago, we adjust company performance all the time, because what you see on paper is not necessarily what reality is. And so we might have the world's most trained doctors. What a surprise, we actually do. We have the doctors who go through the longest training programs in the world between residency and what follows residency, right? The specialties that they take and the board certifications that they take. We might have the greatest amount of oversight on our healthcare industry in the world. The most.
We also require them to take on debt too, because it's not, so they come out.
I'm not a fan. I think education in healthcare needs a lot of work. I would love for you to go there next, actually. I think we need to create a lot more supply, but I also understand the sensitivities of quality control, right? And time, it takes time. And I respect the medical associations that are there driving quality, right? Who haven't necessarily focused on cost so much. Here's another stat for you. In that 78-year number, do we show for the volume of innovation in our industry versus other industries? How many healthcare startups are there in America versus pick any one of those other countries that the Commonwealth tracks?
Well, obviously we're doing a lot more there, and I've seen that, and that's what we got the chance to see at the Innovation Center is really, and in my view, we do need disruption, and that's where some of these companies come in. I can do it better. I see a better way of doing it. Give me the chance, and we try to make the barrier to entry a little bit lower. So if you've got a good idea and you think you've got a better mousetrap, that there's an opportunity for you to test that out.
So that's my favorite stat, because for me, the number two solution for better healthcare in America is better discourse that you and I are doing right now. But number one, forget the talk, it's the action. Are people coming at our challenges? And I agree with you. I think the number one challenge in US healthcare is not how good is US healthcare, but how equitable, how available is the best of US healthcare to everyone who's here. And that we have a lot of work to do because I see those disparities, those inequities all the time. Not so much the subjective ones. I don't know. People do surveys. People say all kinds. It's like the Diet Coke test. I don't always trust what people say. But if there's no practice, there's no practice. If the life expectancy in across the lake from Manhattan, in Queens, in parts of Queens that are literally like a stone's throw away, if that life expectancy is 72, and then you take a train and you travel for 5 minutes and you're in East Manhattan and the life expectancy is 84. That doesn't sit right with me, right? There's something very wrong about that. And yeah, I'm still leaving room for behavioral choices and food and health and all that stuff. But I've also been to the hospitals in both of those zip codes, right? I've been there. I've seen the level of investment that's gone in one area versus you can't travel up York Avenue or First Avenue in Manhattan without seeing one pristine hospital establishment, health system establishment after another, research, income, it's all there, right? A hub of healthcare. So we have to think about how concentrated our healthcare is. And it does speak to some economic incentives that are maybe a little bit too skewed versus incentives that could be a little bit more fairly shared. So we're in agreement there.
Definitely. And there's also the human cost of just not being able to afford the healthcare or being hounded by bill collectors after you go see a doctor, you get a treatment and you had no idea how much it was going to cost. I mean, there's a very real human cost to all of this that is also buried in those numbers that's really important. And
when it's bad, it's really bad. Do take
the
comfort.
level of bankruptcies too. I'm curious your thoughts on the new rules about not counting healthcare debt towards one's credit rating.
Probably helpful. Right? I mean, it's an initial reaction for me, but probably helpful to try to take some of the pressure out of healthcare costs falling on individuals. Fair? And you have to think about who the counterparties are to that. If it's hospital systems or health systems, they don't necessarily rely on patient balances to drive their economics, right? There's been this strange coexistence between patient balances and hospital inflation for 50 years. I find it fascinating that patient obligations or patient balances as part of hospital bills represent a small percentage, 2, 3, 4% on average across the country. Patient balances as a portion of outpatient care represent a growing percentage as high as 15 to 20%. And so the conversation that hospitals are having with payers is very different than the conversation that smaller practices have been having with payers. I actually think that patient balances is healthy. Call me crazy, but when I first showed up 30 years ago, healthcare felt free to a lot of people because patient balances were pretty tiny across the board. So government regulators actually criticized and focused mostly on excess usage back then. It was just too much spend in healthcare. You're driving us crazy. Medicare is going broke. This was 30 years ago. Medicare is still going broke any minute now. Even though Medicare income is a percentage of GDP income, so actually GDP, Medicare income goes up as a result because it's in proportion. But yeah, as a percentage of total GDP, we were in that period. I want to show you something. I want to show you some interesting stuff.
Can I just make one point on that too, and this is getting back to the success of the Innovation Center. And we've been doing some work, or when I was there, on the spillover impact and the fact that there is actually a larger impact on the health system of the Innovation Center's models and the innovations that they were testing than has been demonstrated by just looking at each evaluation for each individual model. And so we're trying to do a better job of capturing what that impact is. And I think it is much larger than maybe it's been shown to be in the past.
So here's an example of some of the impact that you've had, right? This is something that I find endlessly fascinating. Bending the cost curve. You couldn't have a more bent cost curve than this, right? Spend as a percentage of GDP for US healthcare, which as of now, and the latest stats are actually lower, call them 17.3 for 2023, are almost identical with 2009.
Exactly. And nobody can explain why that has happened, but I do think there is an impact of some of these changes and some of the changes in incentives that just we haven't done a very good job of capturing.
Well, this does a pretty decent job of telling you what's happening. If inflation during that period averaged 2 to 3%, give or take. During the last year, and anecdotally, I don't have the stat in front of me, but I can tell you feedback from physicians and seeing CMS refusing to increase physician reimbursements.
Well, some of that's in statute, and so they
Yeah,
may complain, but some of
but
that,
numbers like 0.8% are deflationary on
right?
a comparative basis, right?
Yes.
Same with other professions within healthcare, same with medical equipment. What's interesting is, and look at health insurance actually in the last year. What's interesting is nursing home and hospitals. I think that number has been rock steady throughout the same period. So we're getting into sort of that Japan analogy where, as a sum total, healthcare has actually not been inflationary for 15 years on a relative basis, relative to the rest of the country. It hasn't added to the average cost of living. It's been constant during the 15-year period. It's been 17 cents of every dollar you spend.
I think there's a great story in there, and that's,
It's an
that
amazing
is
story.
exactly what we were trying to do, was bend the
You did it.
cost curve.
You
I
did
think
it.
it's harder to explain what led to that. Why did it happen?
You did it. Here's a more crazy story. You ready? And this is why we need this podcast. Here's an even crazier story. You get to a stat here. Nobody else has done it. So here you are. This is the Commonwealth report. They actually show you at 16.5%. I wonder if they're taking out exports of drugs, which is actually quite smart. Because I actually agree with them. I think it is 16.5%. And in my maths, if you adjust for obesity being uniquely high in the US because we eat the wrong food and we don't do enough exercise as a populace, we're actually at 15%, still higher than everyone else. Here they are, 2009, 16.5%. All these other countries have actually, it's a little bit hidden here, but I studied this closely, they're all trending up. Germany in 2000, here's 11.8%. Let's see where Germany is in 2009. 11.2. So they've gone up nearly 1 in 2009. Every one of these countries is actually trending up. I don't think we calculate ours correctly because we don't adjust for obesity. We just have a much sicker populace to take care of, which is horrible to say because half the populace, the 60% that isn't obese, is the healthiest populace in the world. And the whole populace together is the most productive populace in the world. Nobody works like Americans. Nobody. Maybe the Chinese. Close. Right? But we're killing ourselves and consuming a ton of healthcare in order to do it. And by the way, attaching our healthcare to our jobs, right?
Yeah.
And getting the reward of Medicare, but not really getting the reward of nursing homes and anything outside of treatment, right? We don't really get the infrastructure to grow old peacefully like you do in other countries. Other countries spend less on healthcare and they're spending a lot more on care of their elderly, which is not reflected in these numbers, right? How much does France spend on nursing homes? A lot more than us on a per capita basis. The numbers, they're all over the place. And so what I want to do is make everyone slow down on the headings. American healthcare. I was listening to the Jon Stewart podcast of Mark Cuban a week before I interviewed Mark Cuban. And Jon Stewart, he's a brilliant comedian, God bless him, but not necessarily ready to take on healthcare. But he starts the first sentence, and that's an arrogant thing to say. But I do spend every day of my life, 15 years straight, in healthcare as an operator. He has not. So there is a difference there. Now, it doesn't mean that he hasn't read more, but based on the podcast, I would argue he has not. But he starts the sentence with, American healthcare is irredeemable. And he doesn't phrase it as a question. It's a statement. And that's the part that I'm picking at. These are not statements. These are questions. And so I'm just really excited that I got a chance with you to ask a few questions to try to examine that statement a little bit harder. What are your thoughts?
This was a really fun conversation. You've clearly given this a lot more thought than probably 99.9% of Americans. And I think you're raising some really good questions. And, we're about to enter a debate where where some of the proposals on the table potentially undermine Medicaid. And I think let's think about these questions as we go down and enter this.
You and me, let's bang on doors.
Yeah, exactly. Because there's always a chance to make things better, but there's also a chance to make things worse. And I think
or
watching.
doing anything mistakenly. Yes, agreed. we're faced with all kinds of challenges taking care of 350 million people. It's not easy.
Absolutely.
Liz, I want to thank you for all the work that you've done so far in this beautiful industry that you and I are part of. I was telling a room of 30 CEOs yesterday in San Francisco and another 15 CFOs that we all work for the same company. It's called US Healthcare. All of us, politicians, operators, physicians, we all report to the same brand, US Healthcare. And my dream is to bring the best of US Healthcare to the rest of the world. Because if we don't give the brand the oxygen it needs, they won't take us seriously. And yet we're doing a lot of cool things too. Thank you, Liz. I'm going to follow up with you outside of the podcast and see what else we can do together.
That sounds like fun. Thanks so much. This was a lot of fun.
My pleasure. Bye.